For extracorporeal septal reconstruction, you need, for a good rhinoplasty, you need a strong L-shaped framework. As long as you have a strong L-shaped framework of the septum, you don't need an extracorporeal. But if there is a deformity of the anterior border or of the dorsum, then you have to think about if it's not easier to take out everything to create a new septum than to try by splinting and grafts endonasally to do that.
A few years ago, I did very few of extracorporeal reconstruction, and now I do more and more of extracorporeal reconstruction. I certainly think a patient who has a very deviated septum, particularly the anterior part of the septum that is heavily deviated, or they have a high deviation, and post-traumatic noses. Certainly boxers or patients who have been in road traffic accidents, contact sports players, like certainly in the UK rugby players, all these sort of patients I think are very good candidates for extracorporeal septoplasty. I would say that if I see a septum and I think there's a severe anterior deviation or very high deviation, there's a lot of scarring, these are the patients I would just recommend extracorporeal septoplasty rather than a straightforward septoplasty. And I think that's the decision that you have to make the first time around. In other words, there's no role for doing a septoplasty and then saying, well, I will do extracorporeal septoplasty the second time around. I think it's a big step. It's the first time around you go and do extracorporeal.
The best candidates for an extracorporeal septal rhinoplasty are persons with severe deformities of the nasal septum. These are patients with, for example, crooked nose deformity or sequelae of a big nasal and centrofacial trauma. Sometimes the extracorporeal septal rhinoplasty can be done also in patients with septal lesions, but it's a small population.